Well, good evening, everyone. I was going to say good morning, everyone. Good evening, everyone. We'll let people start filing in and we'll get started in a couple of minutes. Thanks.
You all just tell me when you want me to share my screen.
Shall do. Okay, we just broke through 100 students. So we hope that everyone's enjoying the unseasonably warm weather, and it's going to get even warmer over the next couple of days. So get ready for Indian summer. And a reminder to those of you who are calling in this evening, please send an email to Nicole Sabine, that's NSABINE @delamed.org, to let her know what number you were calling from and that you attended this evening so she can match your number up with the attendance. All righty, well, we're going to go ahead and get started here. So let me arrange my screen just a little bit here. So welcome to the fourth session of Delaware Mini Medical School Fall 2023. And this is the northern version of Mini Medical School. There's a southern version that'll be starting here in a couple of weeks that's emanating from Kent and Sussex counties in Delaware. We have our social media tags down below on this slide. If you're not following us yet, please do follow, like, retweet, as the case may be. We appreciate it. So I think you all are probably familiar with this now. We started the program in 2009. For the next couple of years and for the spring session that has already occurred, we're supported by the American Rescue Plan Act, which is funds that were put out by the federal government through the state of Delaware for COVID pandemic relief. Our hope is through Mini Medical School that some percentage of the people who are on the call are going to say, yeah, medicine, healthcare, public health, that sounds like a great career for me, and you'll pursue it. As we have demonstrated so far, there are no tests or grades other than perhaps the test of successfully logging in. I know that that is sometimes a challenge, and for that we apologize. This fall session is one of the last two sessions that will occur between now and the end of the year, I should say fall series. And interested students, the registration is now open at DelawareMiniMed.org for the next series that starts, I believe, on November the 14th. It's different speakers, different content, and I'll get into a little bit more detail about the Youth Academy in a minute. There's no continuing medical education or continuing education credit for professionals through this. And for participants who attend all 6 sessions live, you will get a signed certificate of achievement that will be signed by Dr. Kate Smith and myself. So program goals is health literacy, letting especially you middle, junior, and high school students and undergrads get exposed to a number of different types of clinical experts and also topics as part of your career exploration and development. This evening, we're joined by Dr. Lee Dresser, and he's going to tell you a little bit about his process to go from being, when he first thought about going into medicine to where he is today. And we also want this to be an opportunity for everyone to speak, ask questions of us and of Dr. Dresser in a safe space. We ask that the questions not be personal in nature, but this is an opportunity to interact with the healthcare provider when it's not a dire situation or they're about to give you a shot of something. So the Delaware Youth Medical Academy, we've been hinting at this We are still refining this. We're now to the point where we can give a little bit more detail on it. So each session, and this is a session tonight, is worth 5 points. During a given series, which is 6 sessions, therefore you can get 30 points. If you get 30 points and you do a reflection paper, and details aren't going to be released about that until right before the time. We don't want to give anyone an unfair head start. Then you will become a member of the Delaware Youth Medical Academy. It's okay if you don't complete all the sessions. You can still do the self-signed certificate. And then if you take first 6 sessions, then 12, then 18, those will build up over time. We encourage you to take as many as you possibly can. Ultimately, you'll get your name on the website if you want. You're going to get an electronic badge, a piece of bling, if you will. Then we're going to give some physical bling. We're not sure what that's going to be yet, whether it's a baseball cap or a keychain or whatever, but we're working on that. There will be a complimentary student membership to become a member of the Academy DPHA. And then if you get to level 3, which is you've done 18 sessions or 3 series, then you can come free to our annual meeting. You'll be recognized at the annual meeting, photographs taken and whatnot. And definitely that would be quite an accomplishment. It's a dedication of time and of learning that'll make a difference on college resumes. So that's the Delaware Youth Medical Academy. And I'm sure that over time, things will develop further. So this evening, we're going to be talking about neurology with Dr. Lee Dresser. Dr. Dresser is a board certified in neurology and sleep medicine. He attended medical school at Wake Forest University, Bowman Gray School of Medicine in North Carolina, and completed his residency at North Carolina Baptist Hospital. Dr. Dresser recently retired from Wilmington Urology Consultants and is the chairperson of the Delaware Stroke Initiative, and sadly is a board member and colleague of all of us at the Academy DPHA. And this will be one of his last official contributions to being a longstanding member and supporter of the Academy DPHA. And at this point, I'm going to stop screen sharing. Dr. Dresser, you can start and we'll turn it over to you. Thank you.
Thanks, Tim. Let's see, it says I'm disabled from screen sharing.
Let me see if I can make that happen.
Okay.
Okay, you want to try now?
Yeah, now it works. Thanks.
Great.
Okay. Okay, well, thank you for all attending tonight. I am going to talk about stroke, and stroke is kind of a good topic for people new to neurology and neurological care, because it really incorporates anatomy of the brain. So you kind of learn 2 things. You learn about stroke, what stroke is, what causes it, how we evaluate it, how we treat it. And then you also, it's kind of like a nature's kind of evil experiment that when stroke affects part of the brain, you kind of learn about that part of the brain and what different parts of the brain, do for us. It is actually something that has over time has taught us what different parts of the brain do. As Tim said, I'm a neurologist and practice mainly general neurology. And a general neurologist takes care of a lot of stroke patients. As you'll see, it's a fairly common, unfortunate problem. And we see a lot of stroke patients in the emergency room. I got interested in medicine probably, in high school. I had a buddy whose mom was a nurse at the local hospital in the area I grew up in the San Francisco Bay Area in California, and was looking for a job. And he was an orderly in the hospital and got me a job as an orderly. And our job was mainly moving patients around, but we also were responsible for helping with CPR if somebody had a cardiac arrest, and kind of various low-level duties that need to be done in the hospital. I just really enjoyed it. I enjoyed being in that environment. I thought it was fascinating. How different medical conditions were treated, and then decided to get a job later on driving an ambulance. I worked as an EMT driving an ambulance and really enjoyed that as well, taking care of emergent medical problems, and that kind of spurred my interest in applying to medical school, and have very much enjoyed my career in medicine. I would encourage all of you, if you haven't done so, or if you have an interest in medicine, especially after participating in the mini medical school, to try to shadow somebody in the medical field. It could be a nurse, a paramedic, a physician assistant, and really kind of get a taste for what it's like. And you might find, boy, this is fascinating, or you might find this is not for me. I'd rather go into accounting or something. But I would definitely encourage you to kind of expose yourself to it, and I think then you really will get a great feel for what is involved with the field of medicine you might be interested in. And then if there's other questions at the end of the talk about medical school and or careers in medicine, I'd be happy to field them. So this is a huge topic that I'm going to go through tonight. Stroke is really a kind of a complicated topic, but I'll give you hopefully a good overview, and then you would be able to have a good idea what stroke is, and how it impacts people, and what we do to prevent it and treat it. So in everything in medicine, it's important to have a definition. So the definition of stroke is a sudden focal neurologic impairment which is related to an interruption of blood supply to part of the central nervous system. As some of you may know, the central nervous system is the brain and the spinal cord. We're going to really be talking about exclusively the brain, but you can have a stroke of the spinal cord. In everything we're really talking about would apply to the spinal cord strokes as well. Fortunately, spinal cord strokes are really rare, so we're not going to really talk much about that. There's another abbreviation that you may have heard of, and you probably will hear about if you haven't, called a TIA. And TIA is not TIA, or Spanish for aunt. It is a transient ischemic attack. So TIA, transient ischemic attack. And it is really the same thing as in terms of symptoms and signs as a stroke, but the TIA, as the T, the transient indicates, is temporary, and it's completely reversible. Just in medicine, as some of you may know, a symptom is something that the patient experiences. It's something that the patient tells you. A sign is something that you detect when you examine the patient or observe the patient. So a headache would be a symptom, a heart murmur would be a sign, something you listen to the heart in order to detect. And we're going to be talking about symptoms and signs of stroke a little bit later on. TIA and stroke are really evaluated pretty much the same way. So we're not going to really talk about TIA much beyond this explanation, but it's a good term to be familiar with, because if you go into medicine or a medical field, or even if you don't, you'll probably hear it in the future. So why would I even take the time to talk about stroke and make you concerned about it? And the reason is because it's a big problem. There are close to 1 million strokes a year. Maybe a third of those are recurrent strokes in people that have already had one. So if you do the math, that's about, in the United States, that's 1 every 45 seconds. It's a real common problem. It is the number 5 cause of death, so in the top of the common causes of death, but it's the number 1 cause of disability for adults. Disability meaning somebody who has weakness, somebody has trouble talking, somebody has trouble walking. So it's a big problem. This is a kind of a busy slide, but you can see that it's an expensive problem. It costs up to $53 billion or more a year, and it is something that is more, as you can see from the map, it's more common on the East Coast, and especially in the South, but quite common on the East Coast as opposed to the West Coast. So for most of us on the East Coast, it's even more important that we're familiar with it. It is a big cause of dementia that people that have had strokes real commonly have trouble with memory and thinking. And for older folks like Mr. Gibbs and myself, thinking and memory are more and more important to be concerned with. You can see that this graph shows that strokes in older people are more likely to be disabling. Younger folks, people like more in their 50s or 60s, don't have as much disability as older folks. There's a lot of things involved with the recovery of stroke. A big theme about stroke's effect on a person in their brain is where in the brain the stroke occurs. And we're going to be talking about that. There's an expression in real estate that the most important things in real estate are location, location, location. And really, it's kind of similar in strokes. There are certain parts of the brain where a stroke can cause relatively mild symptoms, but other parts where it can cause severe, quite disabling symptoms. Also, the age of somebody, there are other medical problems, what medicines they're taking. There's lots of factors that go into the effect of a stroke on someone. This slide just really points out what are the major disabilities that people with stroke will have after the stroke has occurred and they're recovering or recovered. Half of people will have hemiparesis. Hemiparesis means weakness of one side of the body. So that's a big problem. Almost 50% of people will have cognitive deficit, thinking problems, memory problems. Depression occurs in like a third of the people that have had stroke, and 3 out of 10 people who've had a stroke cannot walk without some assistance. So that's we are ambulatory animals, and walking is super important for us. So if you can't walk, that's a big problem. It's important for all of us to know that if somebody has the signs or symptoms of stroke that we're going to talk about, the time is really critical. You want to call 911 if anyone you're around has signs or symptoms of stroke, because it's real important to get to the hospital as soon as possible. There are medicines that dissolve blood clots. That's the number one cause of strokes, or blood clots. And those medicines need to be given to the person as soon as possible. As the bottom of this slide indicates, somebody having a stroke, every minute they lose 2 million brain cells on average. So that's a huge source of injury to the brain, that the sooner you put the brakes on it, the better. The difference of 10 or 15 minutes could determine if somebody walks out of the hospital or if they go out in a wheelchair. The other thing that can be done, in addition to medicines that dissolve blood clots, is specially trained neurointerventional doctors can actually put into the artery little snares, or this is what's called a stent, which can go up into the blood clot and actually trap the blood clot and pull it out of the artery where it's causing the stroke, and can dramatically change the impact on a person. But the brain can only go a very short period of time without blood flow before there's irreversible injury. So time is really important. So what causes stroke? What are the things that cause stroke? This is really the list of things that cause stroke that we can change. So what's called modifiable. I put hypertension or high blood pressure in orange there because it is the most important symptom, or excuse me, most important disease that can cause stroke. So it's real important that everyone, especially older folks, get their blood pressure checked on a regular basis. High blood sugar, which is diabetes, high cholesterol, which is hyperlipidemia, smoking, being overweight, obesity, heart disease, drinking too much alcohol, and just being sedentary, somebody that doesn't get regular exercise, all those things put you at a higher risk for stroke. There are some things that are non-modifiable, things that we can't change that cause stroke. You really can't change your age. And as I mentioned, that older folks are more prone to stroke. You really can't, for the most part, change your genetics, your race, or your sex. But as this slide indicates, there are many modifiable risk factors for stroke. The best stroke is a stroke that never happens. So when we say primary prevention, that's modifying those risk factors before somebody has a stroke. Secondary prevention would be modifying the risk factors after somebody's had a stroke to prevent them from having a second stroke. And approximately a third of all strokes that occur yearly are a recurrent or a second or third stroke. And the things that can be done after somebody's had a stroke would be putting them on blood thinners, lowering their cholesterol, changing lifestyle modifications, stopping smoking, getting more active, eating a healthier diet. And we'll talk about surgery and stents a little bit later here. Oops. So the primary prevention would be addressing those risk factors that I listed. Controlling the blood pressure, super important. High blood pressure accounts for half of all strokes. And we are, as a country, we're getting a lot better at doing this than we were, when I was a young doctor just starting practice. But there's still a lot of people who walk around with high blood pressure and don't know it because it really doesn't have any symptoms. So it's important that we check our blood pressure. So you might ask your parents or your grandparents, when was the last time they had their blood pressure checked? Stop smoking. If you have diabetes, controlling diabetes. If your cholesterol is high, controlling that. Exercise is really helpful for preventing stroke and also heart disease. Trying to be a normal weight. A little alcohol for people over 21 is probably okay, but really don't want more than a little alcohol. If somebody has sleep apnea, we want to make sure they're being treated. And if somebody has heart disease, we want to make sure that their heart disease is being addressed in appropriate fashion. You can do surgery. Vascular surgeons can open up the carotid artery in the neck to give better blood flow to the brain. That can help prevent strokes. A common cause of stroke is a heart condition called atrial fibrillation. And there are actually devices that can be put in the heart to prevent blood clots from going from the heart in somebody with atrial fibrillation to the brain. That would be another type of surgery that can help prevent stroke, usually in people that have had a stroke, but that can even be done in somebody who has not had a stroke yet. So types of stroke, there are two main types of stroke, and one is ischemic and the other one is hemorrhagic. Ischemic is the most common type of stroke. It's 8 out of 9 strokes are ischemic, and that's where a blood clot or a hardening of the artery blocks the artery and prevents blood from getting past the blockage, and that can lead to damage of the brain that is supplied by that blood vessel. Hemorrhagic strokes is where there's bleeding into the brain, into or around the brain, but mainly into the brain, usually from a blood vessel that bursts. The number one cause of things that make a blood vessel burst, which makes sense, would be high blood pressure or hypertension. If the blood pressure is too high, the blood vessel wall may not be able to withstand it, and it will burst and cause a stroke. And I'll show you some pictures of that in just a little while. The ischemic stroke can be due to thrombotic, which is basically hardening of the arteries. You can have hardening of big arteries or little arteries. Embolic is where you have a blood clot break off from some part of the body, usually the heart, and float downstream until it can't go any further because the blood vessel is too small and it gets stuck there, and that blocks the blood flow to that part of the brain. Cryptogenic means, we're not sure if it's one of the other two. There are some strokes where it's really kind of tough to tell. So here's a cartoon that just shows stroke. The top picture of the brain shows the yellow area in the circle there is hardening of the artery, and a red blood clot is formed in the rough areas along the artery. And you can see the brain, to the right there is darkened because that's the part of the brain that is not getting blood. The bottom, cartoon shows nice smooth arteries, but a blood clot that's stuck in there. That would be an embolic stroke or an embolus that came from some other part of the body, usually the heart, but you could come from a large artery that has a blood clot form on it, and rarely from other sources. So hardening of the arteries, atherosclerosis, atherosclerotic, hardening of the arteries, that's the most common cause of a thrombotic stroke. Rarely the blood vessel wall can tear, and that's what we call a dissection, like a torn blood vessel. It can become inflamed, like from an infection. That's pretty rare, but it can happen. Some people can have their blood is more prone to clot. Pretty rare, but it is something we think about. This just shows the process of hardening the arteries or atherosclerosis. Starts with just the kind of cholesterol and fats being deposited in the blood vessel wall. The area can become broken down. The broken down area can have platelets, which are blood cells that are involved in blood clotting, form there. The platelets can attract clotting factors, and that can either lead to a blockage or that can lead to a source of emboli or source of blood clots that can float downstream and cause a stroke. The carotid artery is probably the most important artery involved with stroke, and it supplies the majority of the blood to our brain. As you guys probably know, we have a carotid artery on each side of our neck, and this cartoon shows a dissection. It shows a tear in the blood vessel wall. And this could be something that can happen if somebody has an injury, some like trauma to their neck, if they get hit in the neck, or even something like a car accident can rarely cause the tearing in the blood vessel tears, and that keeps blood from flowing to the brain as normal, and that can cause a stroke. This is just a little drawing that shows spasm of the blood vessel. The top is normal blood vessel and the bottom is spasm. Probably the most common cause of a spasm, which keeps blood from flowing to the brain, would be drugs. The reason we really encourage people not to use drugs, especially things like amphetamine or cocaine, is that those are the two most common drugs that can cause spasm of the arteries. And I've seen a number of young people, otherwise healthy, that were using speed or amphetamines or cocaine, and sadly had strokes. This just shows a picture, the arteriogram, which is a picture of the blood vessels in the brain that is made by squirting dye into the blood vessels. On the left, they're pretty wide open. In the same person, the same blood vessels, you can see how much narrower they are on the right. And that's what vasospasm looks like. This was somebody that actually had an aneurysm burst, and the blood from the aneurysm is very irritating to the blood vessels, and it can cause vasospasm as well. So the embolic strokes that we talked about are where there's an embolus. Embolus is kind of a fancy word for blood clot. That can come from the heart, or it can come, from a roughened area on the artery, like I mentioned. This just shows pictures of things that can cause blood clots to form in the heart. If the heart valve is narrowed and the blood chamber, the top chamber of the heart, is called the atria. If the atrium gets dilated, blood clots can form there. The middle picture shows an artificial heart valve. If somebody has an artificial heart valve, that can cause a blood clot to form. If somebody has a big heart attack, which the lower pictures show, the heart is stunned and doesn't move well, and blood that doesn't move likes to clot. It's real important that blood, continuously circulate. If blood stops moving, it will clot very quickly. And that can happen in a heart that is not beating strongly. And that's also what can happen in this condition, atrial fibrillation, where the heart, the atria is not beating normally, and so blood doesn't get out of it quickly enough, and it can clot. A piece can break off, and that can form a stroke. This just shows common places in the carotid artery that will have atherosclerosis format is where there's a branching, or what we call bifurcation, which is a fancy word for branching. And at branch points, the blood flows a little bit more roughly or turbulently, and those are common places we can see hardening of the artery, atherosclerosis form. So that was ischemic stroke. Ischemic just means lack of blood flow. The other type of stroke is hemorrhagic stroke, and that is basically bleeding into the brain. Once again, high blood pressure, hypertension is a major cause of this. It can also occur if somebody has an aneurysm rupture. Aneurysms are just a weakening of the artery wall, not really a vein, because a vein is low pressure, but the artery, which is the high pressure side of our circulatory system. If an aneurysm ruptures, that can cause bleeding, usually around the brain, but can be into the brain. And then if you have trauma, if you in a bad car accident, if you take a bad fall, if you're struck on the head by a baseball bat or something, that can cause bleeding, usually around the brain. And that can be what's called epidural or subdural. And I'll show you some CAT scans of that in just a minute. Aneurysms are probably the most common cause of blood bleeding in around the brain, what's called the subarachnoid hemorrhage, which is just the area, the arachnoid space is the area around the brain. So here's a drawing of a hemorrhage into the brain. This is a real common area, what we call the basal ganglia. Those areas deep in the brain that are involved with control of movement are really a common, or the most common site for bleeding. And I'll show you why in just a few slides here. Actually, I'll show you why right now. So if you look on the left here, you see those little blood vessels that are going, coming off the large blood vessel. Those are what are called lenticulostriate arteries, and they're very small, kind of, thread-like blood vessels, and they have thin walls, and they're coming right off the big blood vessel. So they're really a setup to bleed if there's too much pressure. And that's where a high blood pressure can cause those blood vessels to rupture. And a high blood pressure also can cause worse atherosclerosis. It just puts too much pressure on the blood vessel wall. Here's a drawing of subarachnoid hemorrhage. This is from an aneurysm that has ruptured, and blood can go. This would be a very bad subarachnoid hemorrhage. You see the red all around the brain, but the blood can go completely around the brain, and that is very irritating to the brain, and the brain does not work well when it is surrounded by blood. Okay, so I mentioned right at the start that stroke is a good way to learn about the anatomy of the brain and the blood supply to the brain. So here is a pretty accurate drawing of the brain. This is the left side of the brain. On the left is the frontal lobe, and right behind the frontal lobe in the middle of the brain is called the parietal lobe. The back of the brain is the occipital lobe, and the bottom area is the temporal lobe. And here's kind of a color-coded, the brain, unfortunately, doesn't actually look like this in real life, but this kind of helps us point out the areas of the brain that are involved with different functionings of our neurologic system. So the purple area is the frontal lobe. The purple and the light blue area, that's involved with control of muscle movement, or what we call the motor center. So that's the kind of the motor that really makes us go, makes our arms move, our face move, our legs move. Right behind that, in the red area, is the parietal lobe, and the parietal lobe is involved with feeling, it's sensation, feeling hot, feeling cold, feeling light touch, feeling a pinprick. All sensation is taken care of in that red part. The orange part, what's the occipital lobe, is responsible for seeing. It's responsible for vision. That's where the light that comes through our eyes stimulates the optic nerve. That's where it's processed. So if somebody has a stroke there, they lose a part of their vision. The yellow areas, the temporal lobe, and temporal lobe is involved with memory. It's also involved with language. The temporal lobe helps us understand language. The frontal lobe helps us generate language. So there's two different kind of divisions of language. One is generating it, like I am, talking to you all right now. And so I'm using my frontal lobe. You all are using your temporal lobe to understand what I'm telling you. So here's just a drawing of the brain, again, showing this is like a slice, kind of like what they call a helicopter slice, like if somebody was, got too close to a helicopter blade and it went right through their head. This is what you would see. And you can see the frontal lobes at the top, the temporal lobes on the side, the occipital lobe at the back there. And this just correlates to the same picture with what you see on a CAT scan. So CAT scans were a big step forward in taking care of neurologic problems. Sadly, I'm old enough to remember before we had CAT scans. CAT scans came into existence in the early 1970s, and MRI scans. This is an MRI scan. Came into existence kind of when I was in the middle of medical school, and the MRI scan is actually even better than a CAT scan. They give us really great pictures inside the body, and in this case, inside the brain. Here's the kind of an important picture of the blood supply to the brain. The aortic arch at the bottom there is coming right off the heart, and the carotid arteries come off, right and left off the aortic arch. On the right side, you have what's called a brachiocephalic trunk, which gives rise, branches to form the carotid artery. The other two most important arteries for the brain are the vertebral arteries, which are right behind the carotid artery, and those supply blood to the back of the brain. But the majority of the blood supply to our brain comes from the carotid arteries. And here's just a picture of the carotid arteries and the vertebral arteries in place. Let me see if I can. Oh, it's horrible at doing. Okay. Hopefully you can all see the cursor here. So here, this is the vertebral artery. It's so called because it goes through the vertebrae, which are the bones of our spine and our neck. And here's the carotid artery in front. And it just shows you, how they are related to the other parts of the anatomy of the head and neck. Let's see. I can't seem to, for some reason, not moving the slides are not advancing. I always have trouble with the cursor.
They might not be advancing because you changed the cursor to do the highlight. You might have to change it back.
Okay.
Or you could click the left arrow button. That would probably do it too.
Okay. All right, so move there. Oh, I can't. Okay, so there's the. Oh, okay, okay. I don't see there. Okay. Yeah, I need to take a Zoom course and learn proper cursor management. Anyway, so here is we're looking at the blood supply in the brain, and this is a drawing of the middle cerebral artery. And the middle cerebral artery is a critical artery. It is the most important artery that comes off the carotid artery. And most of the blood supply from the carotid artery goes into the middle cerebral artery, and it supplies, as this picture shows you, the frontal lobes, the parietal lobes, the temporal lobe, and the occipital lobe. So it supplies the major lobes of the brain. And if you have a stroke here, you can have problems with muscle control, feeling, vision, and language and memory. So it is a critically important blood vessel. So I mentioned, signs and symptoms of stroke. And so finally, we'll talk about what they are. So the name stroke really came from like a stroke from God, a stroke from heaven, just all of a sudden people having trouble with various neurologic functions. So the key is to remember that these are sudden problems and not something that comes on gradually. If somebody says, yeah, I've had worsening numbness on my left foot for the last 2 weeks, that's not a stroke. But if they told you, I all of a sudden couldn't lift up my left arm after I've been sitting and eating with my family, that should really make you worry about a stroke. So sudden weakness, numbness, change in vision, change in speech, sudden very bad headache, sudden problems with balance, sudden loss of consciousness. Those are all things that should make us very concerned, and those would all be symptoms or signs that we would want to call 911 for. Let's see. So as I mentioned before, location is real important. As far as what effect the stroke has on somebody, what part of their brain, and here's a picture of a brain that's had a number of little strokes, and if somebody has a little stroke in the motor control, the muscle control, part of their brain, that will cause weakness. If they have it in the sensory part of their brain, that will cause numbness. Let's try again to trying to see if I can get the cursor here again. Okay. Let's see. Yeah. Okay, yeah, my problems continue, but the let's see.
I see an arrow that you put on there.
Yeah, that was very nice. I have no idea what I did to get that arrow there. Yeah, let me see if I can get out of this. It's a funny thing is you move you can see when something's highlighted, but you can't see the actual cursor. Okay, let's see if this okay. So I'm going to stop my cursor experiment. So the brain is designed in a anatomical fashion so that there are representations of the body in a anatomical organization that helps us understand what parts of the brain control what parts of the body, and if you have an injury like a stroke to that part of the brain, what will be the problem. And this is called the homunculus, and homunculus is Latin for little man, and it is a organization of the brain that goes from the middle of the brain, which represents the feet and the legs, to the top of inside the brain, which will represent the arm, down to the real side of the brain, which represents the face. And it's organized in the same fashion for both control and for feeling. So have a stroke that interferes with the blood supply to the inner part of the brain, the middle part of the brain. That's going to affect problems, or it's going to cause problems with movement and sensation of the feet and legs. And the opposite would be if it affects the sides, we call the lateral part of the brain, that's going to cause problems with the arm and the face. This is probably getting a little bit more into the weeds than you guys need to know. But this just shows which arteries, when they're affected in a stroke, cause what symptoms. ACA is the anterior cerebral artery. That supplies the middle part of the brain. And that, like we mentioned, is the part that of the brain that moves the leg and has sensation for the leg. So if somebody comes into your emergency room with weakness of their leg much more than their arm, you would be thinking an anterior cerebral artery stroke. As I think you probably all know, the right side of the brain controls the left side of the body, and the left side of the brain controls the right side of the body. So we say that causes contralateral, meaning, the other side from where the, and that's true for virtually everyone. MCA stands for middle cerebral artery, and that was the picture I showed you of that very important artery that can cause all sorts of problems if the blood supply is compromised. It can cause weakness of the face, arm, a little bit the leg, trouble with language, trouble with vision. It's a big problem if that blood vessel gets blocked off. Posterior cerebral arteries, PCA, and that supplies the occipital lobe. So if somebody has a posterior cerebral artery that gets blocked off, that's going to cause trouble with seeing, and it's going to cause trouble with seeing the opposite side of the body. So if your right PCA is blocked, then you're going to have trouble seeing your left, part of your visual world. Just a cartoon of somebody that has a stroke that affects their lower part of their brain, the brainstem, and that can cause difficulty with balance. It can cause headaches. It can cause nausea, vomiting. And if it's really bad, like the picture at the bottom shows, it can actually make you go quickly unconscious. In trying to figure out where a stroke occurred, which will also give us some clues to what caused it to occur, there are what are called cortical signs, and that's things that occur when the outside of the brain, which is the cortex, are affected. One of the things would be trouble with language, which is aphasia. Aphasia is where somebody can't get words out, or they can't understand words. Like somebody's listening to my talking here, and all of a sudden it just sounds like I'm speaking Swedish. They can't understand it. Neglect would be where somebody doesn't pay attention to one side of their body. This classically occurs in a right middle cerebral artery stroke, and people just neglect their left side of their body. This can be so severe that, if you're talking to the patient and you hold up their right hand and say, "What is this?" They'll say, "It's my right hand." And you hold up their left hand and you say, "What's this?" And they'll say, "That's your hand." They neglect it. They don't even recognize it as theirs. In a visual field cut is if the occipital lobe is affected, the cortical part, people can't see one whole side of their visual world. They can see everything on the right, but not anything on the left. The other ones are pretty rare. Aprosity means where you couldn't understand somebody's emotion. You couldn't tell if somebody was happy or mad. Prosopagnosia is where you can't recognize somebody's face. You couldn't recognize Taylor Swift's face if you saw her on a commercial. Acalculia, can't calculate. Apraxia is where you can't, even though you're not weak, you just can't do normal activities like combing your hair or brushing your teeth. And anosognosia, all these kind of complicated Latin words. Anosognosia is where you don't recognize you have any problem. It's a lack of recognizing that you're sick. Some things that can occur after a stroke, not necessarily stroke symptoms. Depression, very common. I think I told you 30% or more folks get depression. Fatigue is real common, even if they're getting a good night's sleep, they just don't have any energy, as is anxiety. That basically just shows the once again, the middle cerebral artery and all the critical things it supplies. If somebody has small blood vessels that are affected, like the little tiny blood vessels I showed you a few slides back, those can cause strokes that don't have all those cortical signs. They just cause, just weakness without any trouble talking, without any neglect, without any change in vision, or they can just cause numbness of the one side of the body, or just cause somebody to be clumsy. And these are real common, the smaller vessel strokes. Fortunately, they don't cause as many problems, but they could still paralyze somebody to the point they couldn't use their whole side of their body and couldn't walk. So there are no good strokes. But these type strokes have, as the yellow on the bottom says, no cortical signs. These are just pretty much a single problem like weakness or numbness. And this again just shows kind of an accurate autopsy picture of what those little strokes look like. In the top right is an actual picture of a microscopic view of a tiny little blood vessel that has been closed off from bad atherosclerosis from like somebody that had high blood pressure or uncontrolled diabetes or cigarette smoking or some other type of risk factor. So once again, how somebody's going to do really depends on what part of their brain is affected. Not surprisingly, if people have bilateral, which means both sides of the brain affected by a stroke, they do worse than if you have just one side affected. And there's certain areas of the brain, I won't go into the neuroanatomy, it's probably a little too much for this talk, but certain parts of the brain that are associated with worse prognosis. And that's important for doctors when they admit somebody to the hospital. They say, oh boy, this person's going to need a lot of rehab because this is a type of stroke that's going to cause some major problems. I'm just going to skip that. Okay, so this is now entering the Italian art history portion of the talk. This is, I'm sure some of you know, this is the sculpture of David from the David and Goliath fame. This is Michelangelo did this, and this is a picture from when I went to Florence, Italy. He is 16 feet tall, and just the anatomy is incredible. If you look at David's neck here, you can see the bulge on the side of his neck is the sternocleidomastoid, and the little ridge going across it is the external jugular vein. And that's the anatomical detail is really good. That's exactly what it looks like. And Dr. Smith and I both probably have put IVs into that external jugular vein when we were interns, because it's a good vein that you can get an IV into if there's no other veins in the arm that you can use. Okay, so back to stroke. I'm not sure, you can ask Mr. Gibbs, but I think the Italian art history is going to be on the final examination. So remember what I told you there. So
no exams, no exams.
What? So once again, this is just repeating, showing all the stroke risk factors, and high blood pressure, hypertension is high blood pressure. It is all in caps because that is really important. But the other risk factors are quite important as well. Things you can't change, we talked about. This slide just shows that as we get older, our blood pressure goes up. If I had a nickel for every patient that when I take their blood pressure, I say, oh, your blood pressure is a little high. And they came back and said to me, it's never been high before, I would be a rich man. But the point is blood pressure goes up as we get older, and we just have to keep checking it. Just because your blood pressure was good when you were 25 doesn't mean it's going to be good when you're 45. So how do we diagnose a stroke? We get the history from the patient, we examine them, we get pictures of their brain. Those are all important things. The most important thing is really the history. In all of medicine, you really want to hear from the patient, hear from their family what happened. I mean, what are they feeling? How did it happen? Did it occur suddenly? Things that would lead you to make the diagnosis of a stroke, and if it is a stroke, what kind of stroke? Starting out in the field, when in medicine, when you say in the field, we mean for somebody that is at home, at work, at a store, they're not in the hospital yet. So when they're in the field, the first people they're going to see them are the ambulance folks usually. If somebody calls 911, which we want them to do. And there is a scale called the RACE scale, which puts a number on stroke. Is their face weak? Is their arm weak? Is their leg weak? Are they looking to one side of their body? Are they having trouble talking? 6 quick things the paramedic can assess and then tell over the radio, tell the emergency room doctor, I have a possible stroke patient, the RACE score is 4. And that will let the emergency room doctor know what they need to be thinking of before the patient's even in the hospital. When they get to the hospital, the nurses and the doctors, nurse practitioners, physician assistants, any of the people that are in the emergency medical setting will have a stroke scale. This is the National Institute of Health, NIH stroke scale. And this is something that will also give you a number if you go through these 11 different categories. You're asking, you're assessing how alert are they, how oriented are they, can they follow commands, what's their vision, is their face weak, is their arm weak, is their leg weak, are they clumsy, can they feel, can they talk okay, is their speech slurred or clear, and do they have any extinction? And then you could put a number on it, and the maximum number, which you'd really be dead if you had it, was 42. 0 is normal. Anything below 5 is a mild stroke. Anything probably above 15 is a bad stroke. So if you say I have an NIH stroke scale score of 17, but this is a patient that's had a bad stroke. And it can be used to follow. If they were a 17 on Monday and then there are 19 on Tuesday, something has gotten worse. So CT scans, CAT scans are the picture to get of the brain in the emergency room. Here's a normal CAT scan. This is what it should look like. The gray matter on the outside which is the cortex, looks white. The white matter looks gray on this. That's just how CAT scans are. And that's a normal looking CAT scan. This is a very abnormal looking CAT scan. This is a CAT scan of somebody's had their middle cerebral artery blocked off. When you look at a CAT scan or MRI scan, you're always looking from the feet up. So this is the left middle cerebral artery blocked off, probably been blocked off for a number of hours. This is a bad stroke. This is something that might actually lead to so much pressure in the brain that without emergency measures, the person could die quite quickly. This is what a hemorrhage looks like. Blood in the brain is white. And this is a big hemorrhage on the right side of the brain. This also very, very bad stroke. It can be any size, but obviously the larger it is, the more severe it is. This is a subarachnoid hemorrhage. This is kind of subtle. You might look at this and say, oh, this almost looks normal. But if you look right in the middle of the brain, the area that looks that is white with like two legs coming off either side, that's all blood. That blood that is in the brain from a ruptured aneurysm. So that's a very serious problem as well. This is an epidural hematoma, usually from trauma. On the right is, you see the white is the hemorrhage, and on the left you see how the brain looks after the neurosurgeon has taken the hemorrhage out, and the brain can re-expand to look almost normal. This is what's called a subdural hematoma, almost surely from really bad injury, very, very bad. This is probably somebody that unfortunately didn't survive for such a large area of blood in the brain. So those are all CAT scans. CAT scans you could do like in 30 to 60 seconds. They're very, very quick. You can get a good picture even if the patient's moving a little. MRI gives you better pictures, but it takes longer, maybe takes 10, 15 minutes, and the patient really needs to hold still. This is a normal picture. You can see really nice pictures of all the structures of the brain. In an MRI scan, like a CAT scan, this is not blood, the white area, but the white area is an acute stroke. Tim, I need to run real quickly and get my power cord because I'm about to lose power. So I'll be back in about 10 seconds here.
All right. I'll just, chat and make
shadow
sure.
or something, Kate.
There are a lot of questions in the chat and the Q&A, and we are going to leave some of those for Dr. Dresser. So some of them Nicole and I are answering, and some of them we're going to leave for Dr. Dresser. But they are great questions, and keep them coming. So we do appreciate them.
Okay. Sorry about that.
No worries.
So the white area here is a new stroke, and this is actually an area that's starved of blood, and it's called restricted diffusion. I won't go into all the physics of it, but that's a little stroke. There's a medium stroke, and that's in the occipital lobe. So we know from our anatomy that's going to probably cause occipital lobe on the right. It's going to probably cause trouble seeing to the left. And there's a real bad stroke. That's a middle cerebral artery, like the CAT scan we saw before. You could tell that this is something that's happened recently because the white will go away, in a number of days. So we could say, oh, this is not as a stroke, this is a new stroke. So somebody comes in, you've diagnosed a stroke, you want to know what caused it, what led to it. So we do blood tests. We want to make sure somebody's not severely anemic. If somebody is really, really anemic, they could not get enough blood to their brain. We want to see, do they have diabetes? What's their blood sugar? We want to know what their cholesterol is. If it's a young person and, a young, healthy person, we might do what's called toxicology, which is looking for drugs, looking for things like cocaine, amphetamines, like I mentioned, that can cause strokes. And you can test the blood or you can test the urine for that. And then rarely we look for excessive blood clotting or inflammation or infection. Those are rare causes of stroke. But if there's no other explanation, those are things that we will check. And these can all these things are blood tests, blood or urine tests. We can do sound wave test to look at the heart, and we can also do sound wave tests to look at the carotid arteries. You can do a sound wave test to look at the heart through the chest, which is called transthoracic, or the better one is to do it through the esophagus. And you can actually put a tube into the esophagus, bounce sound waves off the a heart, and you get a picture, which is B on the right here, that shows you the chambers of the heart, and it shows you the valves. And you can see if there's a blood clot in the heart, or you can even see if there's an infection on the valve that could potentially cause a stroke. You can take pictures to look at the actual blood vessels. You can thread a catheter up, oftentimes from the groin, where you get into what's called the femoral artery. You thread the catheter up into the blood vessels in the brain, and then you shoot dye with iodine in it. And iodine will, on an X-ray, will show up like it does on this picture here, and you can see the blood vessels in the brain. You see the carotid artery, and it branches into the middle. Right in the middle of the picture, there's the anterior cerebral artery, which supplies the middle part of the brain, and on the side is the middle cerebral artery, that real important artery that we've been talking about. You can also do this is a CT angiogram, and this, you can just inject dye into any vein and then get a CAT scan of the neck or the head. And you can see the arrow shows you a real narrowing there in this patient. So it gives you a pretty good picture, but you don't have to put catheter directly into the artery. And then you can also use the MRI machine to give you a pretty good picture. And this can be done without any dye, no needles or anything. It's just using the MRI machine to pick up moving blood. And this shows at the bottom of that picture, shows the aortic arch, shows the big branches coming off. In the middle is the neck, and then at the top, it shows you the blood vessels in the brain. So when somebody comes in, they have signs and symptoms suggesting a stroke, you've gotten your tests, you've gotten the CAT scan, or maybe an MRI scan, what do we want to do next? We obviously want to help the brain recover as best possible. We don't want the patient walking up and down the hall. We want them resting in bed. We want to kind of keep their head down so the blood flow is facilitated. You have as good a blood flow to the brain as possible. We want to make sure their oxygen's okay. We want to make sure they're not dehydrated, so we'll give them intravenous fluids. And then, like I mentioned, one of the first things we want to do is see, is this somebody that we can give a clot dissolving medicine to? And if they meet all the criteria, if they meet all the indications for a clot dissolving medication, then we want to give it right away. You obviously want to get a CAT scan. You want to make sure the stroke is not bleeding. If it's bleeding, you don't want to give a clot dissolving medicine. You just want to give the dissolving medicine, or what's called a thrombolytic agent, if there is a blockage. So once again, time is important. The most commonly used blood clot dissolving medicine was this medicine called TPA. We're actually using more and more this other medicine called tenecteplase these days. They will lyse, which means dissolve the blood clot. You want to give it really quick, as I mentioned before. The other thing, and I showed you the picture of this, is the special neurointerventional surgeon can go into the blood vessel, into the artery, either squirt some enzyme to dissolve the blood clot, or more commonly, they can actually mechanically trap that blood clot and pull it out. Once again, you want to do this as soon as possible. This is a little corkscrew that you can put up into the blood clot, and you kind of pull it out, you kind of capture it with this little corkscrew type device. The other thing, this is like a little vacuum cleaner called a penumbra device, and it actually goes up into the blood vessel and kind of vacuums up, sucks up the blood clot, and you can pull it out that way. And the thing that the doctors that do this most commonly are using these days is this device that has a stent, and a stent is like a little mesh tube that is compressed, and you can put it into the blood clot, and then it can have it expand, so it actually kind of expands in the blood clot and traps it, and then you just pull it out. And this has been found to be probably the most effective way to get a blood clot out of the artery. This is some more Italian art history. This is in Siena. Siena is part of Italy, called which is a region called Tuscany. This was on the real pretty tile art that was in the floor of the big cathedral in this beautiful town called Siena. The naked lady is depicting Fortune, the goddess Fortune, and you can see Fortune has a sail in her hands. She's got one foot on a boat. She has the other foot on a ball. And the message to the people that go to church is that you don't really want to trust in Fortune. It's kind of a risky bet. You want to be like the wise man to the on the left, who is holding his book of learning and is sitting firmly on land. Once again, I think this is going to probably show up on the test, Tim, so make sure they know this. Yeah, bad joke. There, as you guys know, there's no test. Okay, so prevention of stroke. We talked about this before, but just to emphasize that you want to modify all the modifiable risk factors. You can use surgery, like we showed, stents. You can use blood thinners. You can use medicine to lower cholesterol. And lifestyle modification is real important. You want to get exercise. You want to eat a healthy diet. You want to not be a cigarette smoker. You don't want to use recreational drugs, especially things like injectable drugs, cocaine, amphetamines. I've gone over the primary risk factors. The surgeons can open up the carotid artery if it's blocked. This just shows a cartoon of how they would operate in the neck. They can take out the yellow portion there is the plaque, and then they can sew the artery up, and you can see there that the blood vessel is completely open now, and that will allow much better blood flow to the brain and prevent blockages. You can actually put a permanent stent in the blocked area. This does not require any cutting into the neck. You can thread a stent up and expand it so that it opens the blocked area. This is helpful for somebody who maybe couldn't tolerate surgery. We use blood thinners real commonly. Lots of people are put on aspirin or these other blood thinners that keep the platelets from sticking together to cause blood clots. For people that have blood clots in their heart, there are a number of different things that can be used that help prevent blood clots from forming the heart. These are good preventing blood clots, but they do have the risk of increasing bleeding. So you have to be real careful that it's dosed correctly and that people don't fall and hit their head, because that could cause some really bad bleeding. This just shows how complicated the blood clotting is, and if there's problems in some of these blood clotting factors, that can make people more prone to have strokes. This shows you where in the blood clotting mechanism all those different medicines work. Once again, I think, Tim, this is on the test too, as I recall. So make sure you guys memorize this. So just, by way of review, we're almost to the end here. Signs and symptoms of stroke are sudden onset, weakness, numbness, change in vision, change in speech, bad headache, a sudden change in balance, or sudden, loss of consciousness or decreasing consciousness. Let me see. Probably. So this is a little cartoon of how aneurysms are treated these days. So let me see if I can. It's a little ad throw here.
VZ here. We are talking about grilling. This is a great dish to teach you inside that you can actually take
So
outside.
we can't see it, we can hear it.
I'm trying to to share it here.
What you need to do is you need to go ahead.
Especially when you're using Harry and David.
Stop your screen share and read through.
Sorry about the ad. Can you see it now, Kate?
Yes.
Yep.
Can you guys see this cartoon?
Yes, we can see it.
Yep.
I'm sorry. Can you guys see the video here?
Yes, we can.
We can see the YouTube page. It's not doing anything just yet.
Okay.
The goal of the treatment is to block
Very
blood
good.
flow into the aneurysm and therefore reduce the risk of aneurysm rupturing. In this procedure, a catheter guided by a wire is inserted through the femoral artery at the groin and threaded all the way to the affected brain artery. The guide wire is removed. A microcatheter carrying a soft platinum coil is introduced inside the initial catheter and is navigated into the aneurysm opening. The coil is then deployed into the aneurysm sac. A small electrical current is passed to detach the coil from the catheter. It may take several coils to fill the aneurysm. The coils induce blood clotting inside the aneurysm and seal it off from the artery. In some cases, when the neck of the aneurysm is too wide, a stent may be used to keep the coils within the aneurysm sac. Stent-assisted coiling involves permanently placing a stent in the artery prior to coiling. The stent acts as a scaffold inside the artery to hold the coils in place.
So that I thought that was just a very cool cartoon that showed how aneurysms are treated prior to being able to put these little coils in, which is just done through a little needle stick. You had to open up, the neurosurgeon had to open up the head, major operation, and go in and put a little clip on the aneurysm to keep it from rupturing. So that is pretty much all I had for today. I'd be happy to entertain questions if there are any.
Oh, indeed. Indeed, there are. So here was what I was going to answer in the chat, but I'll just have you do it instead. If somebody gets frequent migraines, but the scans are shown to be normal, is there a condition that relates to this, and is it something to worry about?
Yeah, in somebody with a typical migraine, the scan will always be normal. And migraines are super common. The number one thing that I treat as a general neurologist, and actually, if somebody has a typical story of migraines and their examination is normal, they really don't need a scan. They don't need a CAT scan or MRI scan because it will never show anything that's causing the headaches. Migraines are generally pretty benign. Rarely a migraine can cause a stroke, especially in a young woman who is on birth control pills and a cigarette smoker and has migraine. That combination is occasionally, though fortunately not oftenly, associated with strokes. Migraines aren't really dangerous, but they are major problem in that they affect somebody's quality of life fortunately, we have a lot of good ways to treat migraine. So if somebody has migraine, by all means, talk to your doctor about it.
There are several good questions here. What medical majors should you shadow if you want to be a neurosurgeon?
If you want to be a neurosurgeon, I mean, probably the best thing would be to shadow a neurosurgeon. If you have the opportunity, neurosurgery is it's fascinating. Neurosurgeons are incredibly skilled, as you know, Kate. I did in my 4th year of medical school, I did a month, as an acting intern in neurosurgery, and I learned a ton. So I think if you're interested in neurosurgery, ideally, it'd be great to spend time with a neurosurgeon.
Yeah, I agree. Can seizures and blood clots be worse for people who have chronic diseases like asthma or diabetes?
In general, any chronic disease you have makes you at a higher risk, for other, conditions. Seizures, in asthma, somebody probably that has a convulsion that could definitely make asthma worse. Blood clotting problems, people have seizures, they oftentimes tend to fall. So, we worry about somebody with seizures with blood clotting problems that they might, fall and especially hit their head and have bleeding into their head.
Yeah. If a patient had radiotherapy on the neck, which could harden the carotid artery or narrow the carotid artery wall, would it increase the risk of stroke to the patient? And if so, how would a patient prevent it?
That's a great question, and it's an absolute yes. I have a good friend that had that happen to. He had throat cancer, and healthy guy, is a triathlete, and he had his carotid artery damaged from that to the point that the carotid artery on one side was actually closed off, and he had a little stroke. It's probably important for those folks that have had that to really stay in close touch with their physician, and they may want to periodically get like a sound wave test to look at the blood vessels in the neck to make sure something's not happening.
Oh, here's a good one. Can lifting really heavy weight cause a stroke?
Very, 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 very rarely. It's probably not something to worry about. It probably would be mainly a problem in somebody that was prone to it anyways, that had like some bad hardening of their blood vessel walls or hardening of the arteries. It's impressive in people that they lift weights, their blood pressure can go up dramatically. Fortunately, virtually never causes any problems. So if you're a healthy person, I'd be more worried about your back than having a stroke.
Yeah, fair. What is a migraine? Is it an escalated form of a headache? Does somebody start off with a headache and then get a migraine, or is it something else?
A migraine is a real common bad, moderate to severe headache that is a neurochemical phenomenon that occurs in a large number of people, like maybe 1 of every 4 women sometime in their life, at least 1 of every 4 women sometime in their life, and maybe 1 of every 10 men will get a migraine. And it is migraines can sometimes begin relatively mild and then over a period of hours, get worse, which would help differentiate it from a stroke. An aneurysm that ruptures causes a very severe headache right away, 0 to 60 in 3 seconds. So if you have a headache slowly getting worse over the course of a day, it might be a migraine, but it's definitely not a stroke. It's not an aneurysm.
You were talking about ADHD medications, and the question says, don't some ADHD medications have amphetamines? Can long-term use of ADHD medications cause stroke?
That's a real good question. Yeah, and like Adderall, probably one of the more common ADHD medicines is amphetamine. And somebody that's on an amphetamine medicine for ADHD just needs to have their blood pressure checked, periodically. If their blood pressure is okay, then they're probably okay. The taking an amphetamine pill like Adderall is, in the appropriate person is quite, safe, and millions of people, take that. You worry about, people that are smoking it, injecting it, snorting it, especially people that maybe aren't healthy to start with. Those are the people that are real high risk for a stroke. But
Would you recommend older adults take a low dose aspirin to prevent a stroke?
No, and people have looked at that. It's a great question also. And if you're a healthy, older adult, then the big studies have shown the aspirin doesn't help you. So if you're healthy, no matter what age, you don't need aspirin.
Okay, I like that plan. Why are women more prone to migraines than men?
That's an excellent question. And I mean, the obvious, the wise ass answer is it's hormones. But why estrogen and progesterone that are much higher in women than men predispose women to migraine? Sadly, it's not really known. It's kind of one of those things. Well, we know it happens, but we're not sure. That's why the people in the audience need to go into medicine and figure out that answer.
Well, it seems like a lot of the people in the medicine in the audience have headache questions because they keep coming in. We have our frequent headaches, something to worry about in teenagers, and what do you do if you keep getting migraines and constantly have to take Tylenol or Advil for them?
I'll give advice. You want to take good care of yourself. So you want to sleep 8 hours a night, keep yourself well hydrated. Oh, perfect timing, Kate. You want to drink like 2 or 3 of those big glasses of fluid that Dr. Smith has.
Dollar store. You can get them from the dollar store.
So don't miss meals. Eat 3 meals a day. Get regular exercise. So sleep, meals, hydration, exercise. I tell all my headache patients to do that. If you're still getting a lot of headaches, talk to your doctor. You don't want to take Tylenol every day or every other day. There are better ways to treat it.
Okay, good. I like that. How does drinking alcohol and smoking cause strokes?
Well, smoking accelerates atherosclerosis, quote unquote, hardening of the arteries. Excessive alcohol, and by excessive alcohol in people 21 or older, I know we have a young crowd, and you really probably good to stay away from alcohol if you're under 21. Excessive alcohol will also accelerate atherosclerosis. In addition, if people are drinking excessive alcohol, it weakens the heart, and it makes you more prone to have irregular heart rhythms or a weak heart, which can lead to blood clots forming and can cause strokes.
Well, thank you so much, Dr. Dresser. We're past 8 o'clock, and you kept going, and we appreciate that. But there does have to be a stopping point. Tim, is there anything that you would like to say to close out the evening?
Just thank you all for attending. We will see you next week. And Dr. Dresser, it's been a pleasure and an honor to work with you. And thanks for closing out your time with us doing MiniMed. We appreciate it.
My pleasure, Mr. Gibbs and Dr. Smith. It's always a pleasure associating with you.
Likewise. Thank you, Dr. Dresser.
Okay, you all take care.
Bye.
Bye-bye.